The broadcast is now starting. All attendees are in listen-only mode.
Hello, I would like to welcome everyone to the IBM Watson Health Executive Webinar Series. Today's presentation is titled Population Health, a New Role for Payers, presented by Dr. William Kessler, Deputy Chief Health Officer and Lead Population Health Officer with IBM Watson Health. Before we begin, I would like to review a few housekeeping items. First, you have a control panel at the right side of your screen. You can minimize and expand this panel by clicking on the arrow in the upper right-hand corner. Second, you can submit questions using the question panel located near the bottom of your screen. We will try to answer as many questions as possible at the end of the presentation. If your question is not answered, we'll respond to you individually after the event. Next, all of the registrants will receive a follow-up message with a link to the recording of today's presentation, and this should arrive within 48 hours following the webinar. This information will be sent to the email with which you registered for this webinar. Next, allow me to introduce Dr. William Kessler. Dr. Kessler has spent his career working at the intersection of clinical care and population health as a practicing primary care internist, health services researcher, and health policy expert. Prior to coming to IBM Watson Health, Dr. Kessler previously served CMS, the Department of Health and Human Services, and the CDC. Dr. Kessler received his medical degree from the University of Massachusetts Medical School, completed residency at Brown University, and is board certified in internal medicine. He has also been recognized with numerous awards, including the Surgeon General's Meritorious Service Award. Today, Dr. Kessler will be discussing the current state of healthcare spending in the U.S., the evolution of care delivery, population management versus total population health, and opportunities for payers and providers to work together to improve population health. Dr. Kessler, the floor is yours.
Thank you so much, Colleen. It's a pleasure to be here with you. And like any good physician, I'm going to start with a couple of case studies. At Children's Hospital in Boston, they found asthma was the leading cause of hospitalization, with 70% of admissions coming from 5 low-income neighborhoods in Boston. So they began a program, first to collaborate with other stakeholders, community health centers, the school department, Head Start, and public health, as well as a number of community groups. They provided culturally and linguistically competent asthma education and case management that was tailored to the needs of low literacy families. They worked with home visits, with community health workers, and with the healthcare system to create care coordination with primary care. However, they found that wasn't enough. They then began to do environmental assessments, remediation, and then finally created a pilot with Medicaid to bundle payments so that Medicaid paid for HEPA vacuums, bedding, and professional pest controls, which ended up reducing emergency department visits, reducing hospitalizations, lowering costs, and improving quality of life. In Charleston, North Carolina, the School of Nursing noted a huge disparity between African Americans and the rest of the community in both diabetes, but particularly concerning in lower limb amputations. Their School of Nursing partnered with health systems, hospitals, community health centers, health insurance plans, the health department, and social service agencies. But in addition, they reached out to lay community organizations, in particular faith-based communities and churches. Within the healthcare system, they distributed evidence-based guidelines, offered continuing medical education and nursing credits on effective diabetes care. They implemented QI teams focused on diabetes. They used clinical registries to find care gaps and get people into care, and used community health workers for outreach. They also work with health plans to change insurance coverage for diabetes foot care and education, covering the cost of equipment, supplies, and medications, and also for self-management education. After several years, this multi-sectoral strategy significantly reduced the rates of amputations and hospitalizations amongst African Americans, increased testing for hemoglobin A1C amongst African Americans, and increased annual lipid testing, significantly reducing the disparity with the rest of the community. So what exactly is population health? David Kindig describes it as the health outcomes of a group of individuals, including the distribution of such outcomes within a group. Not explicit, but understood, it also refers to the social and economic and community factors which influence health, not only the biologic factors. So this gentleman, the bust on the left, is Hippocrates. What may not be known about Hippocrates was that he taught the importance of an ecological view of health. And I am going to read you a quote from Hippocrates because I think it's so relevant today that our understanding of population health goes back a long way. What Hippocrates wrote is, whoever wishes to investigate medicine properly should proceed thus. When one comes into a city, one should consider the waters which the inhabitants use, and the modes in which the inhabitants live, and what are their pursuits, and whether they were fond of drinking and eating to excess and given to indolence, or are fond of exercise and labor. What's interesting to me is how far back Hippocrates understood, and by Hippocrates, not only him as an individual, but the ancient Greeks, they knew about the nature of healing and prevention. But as far back as the Greeks, there was a split. Asclepius, the Greek god of medicine in mythology, had several daughters. Among them, Hygeia was the goddess of prevention, and Panacea being the goddess of cure. So since that time, for 2,000 years, these two perspectives have evolved largely in separate systems. And what's really interesting right now is we're at a moment in time where we are poised to begin to reintegrate the worlds of Hygeia and Panacea with a renewed understanding, with new tools spurred by new technology, and with new policy and political will around payment strategies. Let's go to the seminal work in 2013 by the Institute of Medicine, now the National Academy of Medicine. This is just one of a number of analyses that show that we in the U.S. spend far more per person on health care and get far less. We have shorter lifespans, poorer health, and this is consistent and pervasive over our entire life, over any number of indices of illness and risk. We spend more compared to our economic peers, the Organization for Economic Cooperation and Development, and this is how we spend per capita compared to our peers. But if we were to spend as a percentage, if we were to graph this as a percentage of gross domestic product, it would be a very similar pattern. Economists tell us that fully 1/3 of medical spending in this country is unnecessary. And by unnecessary, they mean not associated with improved health. There's too much use of high-cost care when lower cost or marginally lower cost would be just as effective. Missed opportunities for prevention. Missed opportunities for care coordination, particularly around chronic disease, hospital discharge, and end of life. Inefficient care processes, which lead to errors and excessive testing, and administrative costs. If we think about healthcare as a $2.5 trillion industry in the U.S., and 1/3 of that cost represents a fair amount of resources, if we can only take a fraction of that and apply that back into health and reinvest that into the community, we can both save the economy money and we can really dramatically shift the curve. So we also have shorter lives. Again, here is mortality from non-communicable diseases in our OECD peer groups. We're not really doing that well. Part of this has to do with the underlying or root causes of premature death and disability, sometimes referred to as the social determinants of health. Here we have one of several models. This one was proposed by Steve Schroeder in the New England Journal a number of years back. I picked this one simply because it was the first case in which the classic medical literature began to discuss this. In this model, about 30% of the proportion is genetic disposition, 15% are social circumstances, 5% environmental exposure, healthcare only contributing 10%, and behavioral patterns 40%. David Kindig, in his Wisconsin Health County ranking models, looked at the data but chose a slightly different way of presenting that by taking away genetics, which we couldn't do anything about, and I say yet because that may change in the future, but for the time being, that's our genetic endowment. When you then look at the rest of what's preventable and what we can do with programs and policies, Kindig comes out with a slightly different proportion, 30% due to health behaviors, 20% due to clinical care, social and economic factors are 40%, and the physical environment is 10%, with those programs on the right being the major domain with which to place our efforts. Ali Maqdad at CDC looked at the causes of mortality, and rather than ranking them the way we're used to in terms of cancer and heart disease, he ranked them according to behavioral causes, showing the modifiable behavioral risk factors are the largest cause of premature death and disability. And if you look to the right among the deaths from smoking, that horizontal bar indicates approximately the 200,000 people in this country who had seriously and persistently mental illness, and smoking is a result of that. What this study is a redo of an earlier analysis by McGinnis and Fahey, which in turn, about a decade ago, which showed essentially the same thing, which in turn is based on an earlier analysis of that famous medieval rabbi, physician, and philosopher Maimonides, who said, live sensibly. Among 1,000 people, only one dies a natural death. The rest succumb to irrational modes of living. And I just love that phrase, irrational modes of living. So the economist Kemp Thor looked at medical spending and obesity right as the obesity epidemic was taking off, as an impact of the costs of behavior. So he looked at the time frame 1987 to 2001. Prior to 87, that curve of obesity was relatively flat, and it just started to take off in those years, and now, of course, it has become exponential. But obesity relatively flat in the 1980s. In that 14-year period, the population of obese individuals in the United States increased by about 10%. The per capita healthcare spending for the obese was 30% higher than for non-obese, and the rate of growth in spending was higher for obese and compared to non-obese. 60%, 63% in the obese versus 37% in the non-obese. And obesity counted during that 14-year period for 27% of the growth in spending. Keep in mind that this is only an economic analysis. It does not measure the burden on the individuals with respect to morbidity, mortality, or quality of life. So there's a rich body of literature linking socioeconomic factors to poor health. I've been particularly captivated with the Area Deprivation Index because it really links to some more current incentive programs. But the Area Deprivation Index is an index that is neighborhood-based and is a composite of demographic measures available by through the census in each zip code in the U.S. And so those 17 measures are measures that relate to employment, to income, to home value and rent, to percentage of parents of single-parent households, to households without motor vehicles, and housing units without plumbing, so that they represent an assessment of a neighborhood. The Area Deprivation Index is correlated with mortality rates that are both age and race adjusted for both men and women. But more interestingly, in 2014, Kind et al. Looked at the ADI and hospital readmission and found that in those areas with the worst ADI, they correlated with an increase in hospital readmission with a magnitude that is equal to chronic obstructive pulmonary disease and greater than uncomplicated diabetes. So here's the link between some of the incentive payments that CMS now has and and a sense of place through the Area Deprivation Index. What Betsy Bradley and her colleague Lauren Taylor have done, both in peer-reviewed literature in the New York Times and then in a recent book, is to argue that really what makes a difference in the country's health is not necessarily our spending on medical care, but what we spend on social services, in particular the ratio of social services to medical care. That countries that have higher ratios of social to healthcare spending have better health outcomes, specifically lower infant mortality, fewer low birth weight babies, less premature death, and longer life expectancy. And while they initially looked at different countries, they now have recently published some preliminary data looking at states that show in the U.S. that states and their budgets reflect the same relationships. So this slide is courtesy of Betsy Bradley and shows where we are in the United States compared to our peer countries in the OECD on the basis of ratio of social to health spending. So we really begin to have a mismatch between the social determinants of health and our investment, with far more of our investments on healthcare spending compared to the proportion of healthcare influence on overall health, and less on social service spending. And nationally, if we were to, and Bradley et al. Have done some modeling on this, if we were to equalize this, it would be equivalent to about 1 million to 1.5 million fewer adults with obesity and over 600 fewer neonatal deaths annually. But how are we going to do this? We're in a political and economic environment in which we are unlikely to raise taxes on ourselves to fund social services, and we're unlikely to shift health care spending to social services. So can we transform the healthcare system to focus on health, to collaborate and align with public health and community sectors in another way? And Steve Teutsch and John Fielding give us a hint about potentially how to do that. In this chart from a 2011 JAMA article, they look at combining the social and physical environment with clinical care in a logic model, if you will. So if we look at the bottom to the left, we see people who are well and going all the way over to being seriously ill and then dead. If we look at the vertical, we look at the level of intervention, focusing on the individual all the way up to focusing on societal level interventions. So if we look down in the lower left quadrant, many of the clinical preventive services are in the primary care. They're for primary prevention. As we go over within that clinical setting, disease management and care coordination are for folks who have more chronic illness, and then assisted living and hospice are to improve quality at the end of life. As we go up more towards societal interventions, school health and worksite wellness programs are at the middle, and then sectoral issues such as education, jobs, transportation, agriculture are at the societal level. In this next slide, they map the case of diabetes. So we'll think about the opening case study on the Charleston community. At the left, in the primary care, screening adults for obesity, offering intensive interventions, going right, controlling blood pressure, lipids, and smoking, and then finally dialysis. As we move up into the societal area, screening individuals with hypertension, worksite programs for overweight and obesity, and then we get into behavioral interventions to reduce screen time, enhance school-based phys ed. I would say some of their faith-based interventions around doing foot checks and diabetes education in churches would be up there. And then finally, more structural interventions such as labeling menus and creating walkable and bikeable communities. So a population perspective, recognizes the limitations in our biomedical model and understands that health improvements require population strategies, both public health approaches, but also community-based, multi-sectoral approaches that involve psychosocial wraparound services, and integrating population strategies directly into clinical care, which sometimes is called population-based medicine or population health management. So there is a controversy around the definition of population health, having different meanings for different folks. Is population health what clinicians do, managing the health of their panels, or is population health a broader societal community perspective? Steve Teutsch argues for the term total population health to make a difference between what the clinicians do and what happens at the broader sectoral areas. But there are opportunities to reconcile both of these views. Let's first, though, go into population health management strategies. Organizing a system-level approach with centralized planning, prioritizing of limited resources, sometimes the clinicians will call this stewardship of limited funds, practicing in multidisciplinary teams, care coordination across multiple settings, enhancing access to primary care, and focusing on prevention, empowering patients with self-management, focusing on behaviors and lifestyle, taking an epidemiologic approach, looking at data and analytics, and of course technology, integrating electronic health records, registries, and automated outreach, and finally alternative payment models. Shared savings, global payment, and two-sided risks are also incentivizing many of these strategies. But rather than the clash between the healthcare delivery system and the public health world, we propose one way in which we can reconcile that difference, and that is by considering the individual, the patient, if you will, in the exam room or at the bedside, as belonging to multiple concentrically expanding denominators. That person, of course, is an individual, an N of one, but that person is also within a panel within a practice. That person then is part of a delivery system, lives in a hospital service area, may be enrolled in an accountable care organization or a health plan, and finally that person is a member of a community that may be geographically or culturally defined. And interventions at all three of these levels are necessary in order to achieve true population health. For clinical practices who may be focused on delivering care face-to-face to the person in the exam room, a population strategy may be considering what happens between visits, using registries and tools to improve preventive care, addressing health disparities by thinking about an individual and their social, economic, and cultural factors that may interact with how they interface with recommendations and with the healthcare system, and referring patients to a wider range of community services that are outside of the delivery system, but that may be diabetes prevention programs, strength training in senior centers for the elderly, or any number of other of those sorts of services. Payer strategies would be medical homes, primary care medical homes, and care management payments that help practices to support the infrastructure to do these approaches by helping to link practices and patients to the community support. An important key is community health workers and the ability to pay for salaries of community health workers, who are folks sometimes back in the 60s referred to as barefoot doctors in the third world, who are lay individuals who come from affected communities, who can link patients to those communities, can help with translation, appointment scheduling, referrals, transportation, and certainly education within the community. For delivery systems such as hospitals that are focused on delivering healthcare services to those who walk in their doors, population-based approaches may be community health needs assessment. We know the Affordable Care Act creates an incentive for this through a requirement that not-for-profit hospitals do a public health style community health needs assessment and then program some of their charitable dollars towards those needs. We also know that the IRS has given hospitals much more leeway to do what's called community building, but investing in community health, not only in the individual patients through health fairs, but allowing them through their 990 forms to count for community benefits, investment in workplace, in sidewalks and playgrounds, in employment. So the IRS has taken in the past few years an incredibly expansive view of hospitals investing their community benefit dollars back into health-related, not necessarily clinical activity. And finally, collaborating with other organizations to support those non-medical services delivered in community settings. Payer strategies might be performance-based alternative payment models, such as accountable care organizations that incentivize investment by holding these systems accountable for cost and quality metrics and bending the curve over time in such a way that simply having more lean production can't possibly achieve those outcomes, but requiring health systems to go beyond simply more efficient delivery, but to really address those community health needs. For health plans, in the Medicaid and Medicare world, contracted plans offer greater flexibility than fee-for-service to pay for population health services. So CMS may be limited in paying for community-based services that are more upstream, but if they hold and pay for the health plans to do that, health plans have a lot more flexibility. Some managed care organizations cover bicycle helmets, car seats. They participate in the diabetes prevention program or the March of Dimes Baby and Me tobacco-free program as examples of that. For communities and states, Medicaid has historically covered many non-medical support services, and through their waivers and demonstrations, states are becoming really creative in terms of additional opportunities to invest in upstream strategies. Vermont, for example, will invest in therapeutic daycare for children of addicted mothers to get them out of the house and into a nurturing, supportive environment in the newborn period to help with growth and development. And certainly daycare is not traditionally a clinical intervention, but Medicaid rather, can pay for that. States have been funded through CMS to use multiple levers for health system transformation and are creating some health plans that are focusing on population health. Excuse me. And finally, Accountable Health Communities is a grant that the CMS Innovation Center has that are helping ACOs and other health systems to test whether the linkage, the organizational linkage between the health delivery system and some of those broader community services can result in better quality and better health outcomes at a lower cost. I'd like to call your attention to one specific example. The Association for Community Affiliated Health Plans had a white paper referenced here that looks at case studies of Medicaid managed care plans leveraging their Medicaid contracts. And by this I mean that Medicaid isn't necessarily paying for all these upstream activities. They can pay certainly for more than the fee-for-service world, but what some of these community plans have done is they've taken the core Medicaid funding and through sponsorships and grants and partnerships with government and nonprofit and foundations have collaboratively invested in housing support, employment initiatives, literacy programs, and even programs for overcoming food security for folks living in food deserts. Turning our attention to health disparities, the Institute of Medicine, again, now the National Academy of Medicine, in its seminal report called Unequal Treatment, really defined health disparities as inequalities among racial and ethnic groups and other disadvantaged populations. They noted differences in health status and outcomes based upon race or ethnicity or disability, which are somewhat reflected in differences in access and utilization of care, somewhat reflected in quality of care, But what's really interesting and highly problematic is that these disparities occurred even when controlled for employment, insurance, and income. So there is something fundamental about race and ethnicity and disability status that transcends the economic sphere that lends itself to unequal quality and unequal outcomes. Addressing health disparities can be amenable to a population health approach. I would argue that a population health approach is essential. But recognizing that health disparities are not simply immutable, but that within the clinical care system, culturally effective and patient-centered care work. There are a number of resources available, including the CLASS, or a series of about a dozen standards for culturally and linguistically appropriate services, some of which are mandated by federal law, others of which are aspirational and really constitute best practices. Looking ahead, there are significant opportunities, I think, for population health based upon the recent developments and advancements in technology. Cognitive computing, machine learning, natural language processing, and big data and advanced data analytics offer us an unprecedented ability to really address some of these issues through newer and evolving tools. So staying on the health disparities issue, patient similarity analysis, which allows for clinicians to have decision support tools in which within a minute or two they can go back and create retrospective cohorts based upon patients that look just like the patients in front of them. And so these patients may not have been included in clinical guidelines or in randomized controlled trials. We know that a lot of the clinical evidence is based on an ideal population, relatively healthy, that's underrepresenting the elderly, the disabled, racial and ethnic minority, and children. And so real-world evidence, by doing these instantaneous retrospective cohorts, by sifting through massive amounts of data, can look at how patients who look just like the patient in front of you may respond to different treatments, not necessarily to replace evidence-based guidelines, but to supplement them. We know that big data analytics can integrate multiple data sources, from public health surveillance to the exogenous data from the social determinants of health, from economic and place-based measures, from people's behavioral measures around perhaps their wearables, perhaps implantables, and perhaps from their behavioral information that is accumulated on their web-based searching, in which they would freely give to an organization who then in turn provides value by creating cognitive and behavioral nudges to help them adhere to lifestyle or medication regimen. We know that there's an incredible use case for big data analytics in risk stratification and predictive analytics, identifying those care gaps, figuring out who is likely to decompensate. We know from our current risk models that we can tell who are at high risk, who may not be at high risk. But with the use of advanced analytics, with the incorporation of exogenous data, social determinants, might we be able to identify who would who is generally at high risk, but who may be at high risk in the next week or in the next 10 days, for which we would have to give extra intervention. We know that embedding measures of population health into practice through assessment, improvement, and accountability is a very important strategy, and we have the ability through the EHR to reduce the burden. We haven't done that yet. The EHR is frequently problematic, but we have the ability through natural language processing and having people interact with their medical records and their computing systems more naturally to be able to reduce the burden and to create a more meaningful set of performance metrics based not on billing systems but on really what happens in the clinical interaction. We know that we can support practice infrastructure for some of the newer value-based purchasing and alternative payment models that are being promulgated. We know that some of this technology can facilitate collaboration and alignment across the care team, across organizations and sectors. And finally, we know that behavioral economics and cognitive psychology and using those tools and those data can really improve and provide nudges, behavioral nudges for patients and for caregivers and for doctors as we interact with the system. And so with that, I would like to thank you very much for joining us. I would like to open it up for questions and dialogue.
Thank you, Dr. Kessler. So just a reminder to the audience, at this time, you can submit your questions using the question panel located near the bottom, the question panel located near the bottom of your control panel on your screen. We'll take the time to answer as many questions as we can today, and we'll take a moment to let some of the questions come through. And again, I know we've been asked this question several times throughout the presentation. You know, will the recording be available that includes the visuals, and that will be sent to all registrants. So the first question that we have, just a moment, let's tee this one up. Dr. Kessler, what should the top priority be for providers who are just starting a population health program?
Great question. So I'd break that down. If someone's just starting, they've got the vision. They know that they want to reach out, and so I would say that's probably the first place to go is culture. Changing our mental model about how we are trained, how we interact, is so important. But it sounds like the questioner is largely there. But if it's a team, if it's one practice within a broader system, working with your peers to change culture. Secondly is seeking out partners. We hear in medicine about the fourth aim and the triple aim, which is better physician engagement, the need to restore the joy to the practice of medicine, how overwhelmed docs are. And by seeking to create multidisciplinary teams where the doc or the health care office doesn't have to do this all themselves is so important. So figuring out who to partner with. It might be a local public health department. It might be a local United Way. It might be social workers at a hospital or a senior center. But understanding that you don't have to do it yourself, that working within teams, bringing social workers, community health workers, and nurses into the mix, hugely important. Then I'd start thinking about going from a patient perspective to a panel perspective. The use of registries is really, really helpful. Registries can start off simply by being pen and paper lists, identifying care gaps. But once you start with that, you're quickly going to want to look at other opportunities to leverage automation, because efficiency and cost are certainly important. But identifying in a registry, again, it can be a spreadsheet or it can be some more sophisticated tools that look at care gaps and automate outreach. I know there are tools that automate outreach that simply provide, for the low-risk patients, emails, texts, letters, phone messages, and reserve for the folks that have higher risks, more intensive ways of getting them back into care. So thinking about quality improvement and looking at how one might take the system, the microsystem within the practice, and through rapid cycle improvement, quick mini experiments around improvement with assessing how they end up being effective or not effective, and then rapidly innovating on that. Sort of adopting that quality improvement strategy will really, really help as well.
Great, thank you. I hope the individual asking that question was taking some notes because that was several great pointers. The next one kind of ties into that, I'd say. It's a little bit of a lead-in, so I'll go ahead and read that one aloud. New approaches to addressing social determinants often include making connections to the community resources in clinical settings, like community health workers. However, there are often not enough resources to connect people to, especially with regard to housing. How can the delivery system address the supply side issue? I guess we just want your opinion maybe on that.
Yeah, so you're really talking about some really, really challenging issues. What I learned a few years ago when I was at the CMS Innovation Center is that there is just like there's public health systems, there are whole systems in communities for housing. So, for example, there are community development funds that are supported by the Fed and by the banking industry. There are local community banks that have as its charter to make investments, just like hospitals have in its charter. And so that there are infrastructures at the state, local, and national level. And for many of us in healthcare, at least for me, for many years, this was invisible to me. So I'm going to say it's going to be very challenging for the healthcare sector to address this by themselves. But I think there's huge power in multi-sectoral collaboration. So foundations, charitable organizations, the banking sector, all are opportunities to leverage whatever resources there are. And I would also suggest from a philosophical point of view, yes, it's important to leverage the resources. There are probably more of them than maybe initially apparent, but advocacy is huge. And so all of this can leverage the existing resources, but at some point, collaboration around advocacy, going to the legislature and other policymakers, and that's where those of us in health have tremendous influence. As key opinion leaders in our states and communities, people look to folks in the health industry as being articulate spokespeople for the health of our communities and our patients. And I feel we probably don't do enough with advocacy. I think in part because we're not trained in that area. We tend to think of ourselves more as advocating for the individual patient. But I think collectively we can have a real powerful voice.
Great. Thank you, Dr. Kessler. The next question, what do you believe the role is for hospitals in the population health universe you have described? So hospitals versus, I guess, primary care.
Well, first of all, I think hospitals are key leaders in health and healthcare, and they're vital economic engines for their community, and they have oftentimes a very powerful voice with policymakers. So I think hospitals are an absolutely key part of this equation. Many hospitals are looking at a changing environment as we move from a fee-for-service to a more population health perspective. They're caught in that changing paradigm in which they need to fill their beds in a volume-based reimbursement system, and the incentives have yet to catch up in terms of reinforcing keeping the community healthy. So I think hospitals have a role to play in helping payers figure out what the best ways of aligning those incentives and of phasing those incentives in so that hospitals can keep their doors open as the system transforms into a truly a total population health perspective. I think that hospitals can shift from thinking about themselves as taking care of people who come in their door, to thinking about how they can take care of the community. The IRS, as I said earlier, has given hospitals tremendous leeway in terms of investing some of their community charitable dollars, at least the nonprofit, into more strategic ways. So moving from health fairs where you look at measuring blood pressure and testing lipids to thinking truly about what are the needs of the community through these community health needs assessments, and then how do we invest. But hospitals shouldn't have to do it alone. So this is where hospitals may, an earlier question talked about housing, where hospitals may get together with the banks in the community and the community development fund and think about housing if that's one of the key areas. If the housing stock is poor, if there are issues of lead poisoning and asthma, maybe being part of a coalition that addresses that.
Yeah, a lot of these questions are kind of tying together. I can see that. This next question takes a little different turn. Is the ADI score available for certain areas, or would we need to obtain data for our population and compute the score?
So that's an easy one. The ADI is available on a web lookup tool for free down to the zip code level. I've talked to engineers at one of our companies in IBM Currum who have the ADI down to the block level. But at this point, it's available very, very easily at the zip code level.
Thank you. I'm glad that one had a short answer because we still have several questions that we want to try to get through. The next one, are you aware of any studies that have tested different methods of intervention implementation based on social determinants of health? For example, how would diabetic education be offered differently to individuals with low health literacy?
Yes, I think that there is a rich body of literature, and I'm also going to go back to my time at the CMS Innovation Center, where they had an award mechanism called the Healthcare Innovation Awards, and so there was a lot of rapid cycle testing and innovation. At the Innovation Center, it was specifically about how to pay for these services and whether or not they could improve quality and improve health outcomes and lower the cost. But yes, in the public health and social services literature, you'd find a lot of material.
Okay, thank you. We might look to maybe provide, like you said, maybe they could check out CMS site to get some links to that information. The next question is it's similar to one that you answered, so maybe a little bit of a reiteration, but let me pull this one back up. Just one moment. Got a lot of them coming through. Thank you guys for asking so many great questions today. This person says, how do you think, this is kind of where you were talking about the hospitals tying in with maybe financial organizations. This individual, Mr. Howard, asked, how do you think communities or health organizations can initiate the culture change necessary to enable community health improvement?
Boy, culture change initiation is hard. My experience has been that it takes leadership, and that when I've looked back and seen those case histories of successful culture change within organizations or within communities, then it always seems to hinge on a leader or several leaders getting together and taking the initiative. I suspect that there's probably a literature on how to systematize that, how to translate that that essence of what the force of personality of enlightened leaders bring. I'm just not a student of that literature, and so I couldn't be able to cite it. But I think it takes people of vision who have the energy, who have the passion and the commitment, who are skilled at partnership to just start. Just as an aside, while you're waiting for the next question, when CMS looked at its accountable care organizations, and particularly the pioneer ACOs, the more advanced ones, and they looked at what were the elements of success, they looked at the large and the small, rural versus urban, tech versus not tech, and it turned out that leadership and a commitment to do the work, to see the priority, a commitment to look at data and evidence and to go beyond simply their day-to-day routine to a culture of improvement, that those intangibles really were the key success factor across all of the ACOs.
Thank you, Dr. Kessler. The next question coming in, how can practices with limited time control their patient panel access to to high-cost ED visits, imaging tests, SNFs, and other potentially unnecessary high-cost encounters?
So if I'm understanding the question, you've got a busy primary care practice. They want to be effective stewards, and so choosing, and maybe they want to do well in a risk environment, choosing evidence-based care, high-value care, and trying to eliminate low-value care. I think that there are a couple of ways. I would say on the basic level, people should be familiar with the Choosing Wisely campaign. This was done by a number of specialty societies. The American College of Physicians, which is my specialty society, was a key leader in that area, but there were others. So this is physicians themselves looking at ranking the value of the care and coming up with lists of lower value care that shouldn't be done to complement some of the evidence-based guidelines. So the great thing about that is that it's rewarded, it's initiated by a professional incentive rather than an external monetary incentive. So many of us believe that economic incentives are helpful, maybe even necessary, but that the most powerful incentive is the professional incentive to do right and to do good. So once again, what are some of the tools? I think starting out by simply looking at Choosing Wisely, following evidence-based medicine, but also looking at some of the clinical decision support tools, looking at things such as UpToDate, looking at, and this is where health plans come in. I mean, the title of the talk is Payers. So, you know, in the 90s, health plans, in the 80s and 90s, health plans were all about rationing care, creating a gatekeeper. I think they've moved beyond that to looking at more decision support tools, tools to help with high-cost radiology and high-cost imaging, maybe putting a few minor barriers with minor friction, you know, such as prior auths, but I think health plans can and can continue to do a better job. And then lastly, by empowering patients, by putting some consumerism into health plan design through any number of ways, smart shopper type of programs with education and incentive. I'm hoping that answers the question.
I agree. At least gives them a starting place for sure. We have a next question coming in from Aaron Conlon. From a population health perspective, is it better to focus on patients losing weight or rather focus on all the conditions they may have, for example, hypertension, diabetes, hyperlipidemia? So I think it's probably a matter of opinion, but we might like to hear yours.
Right. As someone who values evidence-based medicine, I've been asked to shoot from the hip, and that's sort of challenging. So rather than judgment, I would frame this by saying, as a clinician, you can overwhelm a patient And so it is important, like the questioner suggests, to choose your battles, not unlike raising a kid. And so part of that goes to what is the most immediate short-term threat. Part of that goes to assessing the behavioral readiness of a patient to change, and then going with what they're ready to do. So if you've got a smoker who's an alcoholic, who's obese, what are their intrinsic motivations? Is it stopping smoking because of a cough? Is it trying to lose weight because of self-image? Is it their children or grandchildren? And so a little bit of motivational interviewing to find out what matters to the patient and where they are with regards to their readiness to change. And then having your own clinical judgment about what are the more important and immediate health concerns. But I think it's a negotiation between provider and patient, and it requires flexibility. I would also say that some of the newer potentials for using cognitive computing, this is a great use case. So, for example, if we could begin to incorporate the data in an electronic health record with patient preference data, with knowledge about the meds that they're taking and the multiple chronic conditions, might we have a cognitive-based analytic decision support tool that could suggest for that individual patient what their priorities are, based upon better predictive analytics. We're not there yet, but that's certainly something that we're developing at Watson Health that would supplement the judgment.
Okay, thank you, Dr. Kessler. I knew that one was a touchy one, but I thought we'd go ahead and get that out for everyone to hear. Oh, yeah. We have two questions that are fairly similar, talking about the healthcare system today being more patient-centric. So one person in their question refers to their EHR as being patient-centric. The other says much of the healthcare system overall is patient-centric. And they both suggest how can technology be developed, or is, I'm guessing, inferred if there is some, developed to improved outcomes for whole populations versus patient-centric.
So that's the total population health versus population health management. When I first heard the term precision medicine, it was in the context of genomics. It was all about highly personalized, genetic mutations. And I thought it was the antithesis of what I cared about, which is population health. And I began to realize that not only does precision medicine deal with one's genomics, but you can have a precision public health, and the opportunities for big data and advanced analytics can begin to bridge that gap between ultra-personalized medicine and populations. And so I'll look at several of those use cases. I think first in terms of technology, right now technology is certainly in the health area better than pen and paper records, but nowhere near where it should be in terms of usability and features. And I think that the opportunity for natural language processing and developing these cognitive systems that can interact with people in a more natural way can visualize data and present them in a dashboard that synthesizes a lot of complex information to provide actionable insight. I think that's a huge opportunity. And if we do it for the physician and the clinician and the team, and then provide them personalized nudges in how they can do a better job. I may be great at referring my patients to the tobacco quit line, but I may forget to screen for depression and anxiety using a PHQ-9. If I can be nudged in my primary care visit based upon patient characteristics to say, here, do the brief screening on depression, that certainly may help me care for my patients better. On the patient level, if we can begin to provide those personalized nudges around medication adherence and lifestyle, that would be great. For example, we have an app that I've seen in development that's an iPhone app that can take a picture of your plate and can analyze what's on there and tell you what are the calorie, the portion size, the diabetic exchanges, how much you need to go to a gym in order to work that off, what you need to do in terms of your insulin. So providing those tools for a patient can certainly help. If I go beyond that into the community, policymakers, clinicians, both need a better insight into what the risks are in their community and their patient panel. And by combining the clinical data in the record with exogenous data on social determinants, can we improve our predictive analytics? Can we point to better actionable insights based upon a detailed knowledge of the individual patients, but also aggregating them into populations? And I think that's how we make these systems both patient-centric and population-centric.
Thank you so much for that response, Dr. Kessler. At this time, we're at the top of the hour, actually a couple minutes past, so we are going to conclude our Q&A. For those of you who have submitted questions that weren't answered aloud today, we will get those responded to digitally. Thankfully, the system records those. I would like to thank you, Dr. Kessler, for your time today in presenting for our audience. As a reminder to the audience, you will receive a follow-up email that includes a link to the recording within 2 business days. And again, it will be via the email address that you registered, used for registering for the session today. Also, if you wouldn't mind taking the brief survey when you log off the webinar, it helps us to learn about what was effective and how we can improve future webinar for all of our attendees. At this time, the webcast is ended. Thank you for attending. Have a wonderful day.